Good evening and welcome to the January 7th, 2020 American Association for Geriatric Psychiatry educational webinar. My name is Lisa Boyle and I'm the moderator and one of the presenters for today's webinar. I'm a geriatric psychiatrist at the University of Wisconsin and a geriatric psychiatrist at the William S. Middleton Veterans Memorial Hospital in Madison, Wisconsin. I'm joined today by Doctors Julie Phillips, Susan Schultz, Audra Yadek, and Mohammed Aslam. Here are our disclosure slides. We have no significant financial conflicts to report. Next slide, please. Our title of our presentation today is Using Telehealth Technology to Improve Access and Quality of Mental Health Care to Older Adults. Dr. Phillips will be presenting initially, and she is a board-certified geriatric psychiatrist providing telehealth consultation for VISN 23, comprising a 5-state region in the Central Plains. She'll be followed by Dr. Audra Yadek, and she is an adjunct professor of psychiatry at the University of Oklahoma and medical director of the inpatient geriatric psychiatry unit at the Oklahoma City VA. Dr. Susan Schultz is a professor of psychiatry at the University of South Florida and retains an adjunct position at the University of Iowa as well. She has conducted research in Alzheimer's disease and late life mental disorders for many years and is a past president of the AAGP. For the last 5 years, she has been with the Geriatric Psychiatry program at the James Haley VA in Tampa, and she has developed an outpatient telepsychiatry clinic for older veterans there. And Dr. Mohammed Aslam will be our discussant today, and he is a professor of clinical psychiatry at the University of Cincinnati Medical Center and staff psychiatrist at the VA Medical Center in Cincinnati. Before we start the session for today, I have a couple of announcements. We really appreciate you joining us today. The AAGP webinar's purpose is to educate, to share experiences, and to stimulate discussion. We invite everyone to ask questions and to participate in the webinar at any time during the presentation by typing your questions into the Q&A box and comments in the chat box. Following the presentations, we'll have our speakers respond to your questions and comments at the end today. Also, we will have an opportunity for further discussion at the end of today's presentations when we will ask audience members who wish to speak and share your experiences to use the raise hand function in order to communicate that you would like to talk. Today's presentation will be recorded and posted on the AAGP website, so you may view it again. The evaluation link will show at the end of the webinar. If you missed the link, a follow-up email will be sent tomorrow with the link included. The next AAGP webinar will be on Thursday, February 4th at 6 p.m. Eastern, titled A Busy Year in Geriatric Mental Health Advocacy. Next slide, please. So these are our learning objectives that we hope to accomplish today. We'd like to really kind of use this time to be able to share our experiences and talk about different treatment settings and patient populations that benefit from telehealth services, and further discuss strengths and weaknesses of methods for conducting visits through telehealth, and also strategies for expansion of our clinical and teaching practices at the VA in the future. So just for some context, our group initially put the idea of this talk together in the spring and summer of 2019. And at that time, little did we know that we would be facing a global pandemic the following year, which has caused such widespread transformation of the delivery of our mental health services, as well as opportunities for innovation and dissemination of telepsychiatry services, not just at the VA, but across the systems of care. So we wanted to kind of start because we know that a lot of us are using this now. So we have a couple of poll questions that we were hoping that you could take part in, just so we know kind of the measure of where everyone's at. The first question is, are you currently working at the VA? And the second question is, are you using telehealth? So it looks like the majority of people are not currently at the VA. And it looks like there's about 10% of us who are not using telehealth currently, but almost 2/3 of us have been using it, especially since COVID-19. Thank you. So next slide, please. So we know that our veterans are aging and that we need to continue to outreach and deliver services to more and more of our veterans that are aging, including mental health services. And the VA has been providing various resources for telehealth services even before COVID started. And so Dr. Phillips and Yadek, next slide, please, are going to be starting us off by sharing their experiences with delivering telehealth services for vets in long-term care settings. Next slide, Dr. Yadek, or I'm sorry, Dr. Phillips is going to go first.
Thank you. Hello, my name is Dr. Julie Phillips. Thank you guys for joining me. I am the geriatric consultant for Vision 23 Clinical Resource Hub here in a 5-state region, including Iowa, Nebraska, North and South Dakota, and Minnesota. Next slide, please. You know, my program sort of grew organically. It started way back in 2012 as a collateral duty when I was with the local Lincoln VA covering a local veterans home. In 2018, this program expanded to such a point that I was transferred over to the Vision 23 Clinical Resource Hub to continue geriatric consultation and expansion of coverage. In 2020, as we all know, COVID-19 pandemic hit, which limited the face-to-face visits with veterans further, along with limiting family visits, face-to-face meetings with staff, and so on and so forth. So telehealth technology really became more important to the entire region. Next slide. My current consultative services are a pretty broad swath. So I do what we call CVT, or clinical video telehealth, to CLC, which is an acronym for Community Living Center or VA run rehabilitation and long-term care settings, covering facilities in all 5 states. I also do VA Video Connect, or VVC, which is home consultation to veterans and caregivers through home-based primary care teams in Nebraska, as well as those that aren't enrolled but are living independently. I provide e-consultative services in all 5 states, which is a chart review with or without a team meeting. I still provide coverage to the Central Nebraska Veterans Home. I also provide all of these services through a telehealth service agreement with the local facilities in the Clinical Resource Hub. The last thing I do to help local providers manage behaviors, especially with dementia, is attend several team meetings a week when requested by the local site through telehealth technology. Next slide. The consultation model really is important to me. The primary provider or the local team would request a consult from me, which is reviewed by myself, usually within 24 business hours when it reaches my attention. It's scheduled by the local telehealth administrative staff. The chart is reviewed prior to me seeing the veteran. And then I visit with not only the veteran, but the team members that are taking care of the veteran, and as much as possible, family involvement for the interview so that consent is obtained as well as collateral information. So during these times, since they are not able to appear on screen, if the veteran is already located in a CLC or a VA-run rehabilitation facility, we will contact them by speakerphone. And then I give recommendations for medication changes, any further diagnostic studies, and follow-up as needed is placed in the chart the same day that I see the patient. Local providers will then communicate results if needed to the consultant. So if I say, hey, you need to get these lab tests done, they will let me know when they are done because these are only recommendations. I don't put any orders in the chart. Next slide. The benefits, these 5 states now have access to a geriatric consultant within 1 business day if needed. Before this, there were no geriatric specialists in the 5-state region outside the Minneapolis area. Teams and families are actively involved in the consult, providing an avenue of empowerment and development of critical thinking to those involved in the care of veterans. So if they are rehab or inpatient units that I frequently get consults from, they'll say, you know what, we already tried these behavior interventions that you recommended on patient X. And they can go through that problem solving process, which just furthers their own geriatric education. Team meetings and e-consultation allows further avenues for informal education on geropsychiatry concerns. Next slide. There are some challenges. The veteran's understanding of what's happening on the screen may be limited due to cognitive loss. Once again, this is overcome with local staff and family involvement. Hearing as well as visual impairment can also limit this, but it's mitigated once again by having care members present for the interview and, for example, repeating questions. Assistive devices are also used. It can be feast or famine. There are days that I may not see a single patient and I just do chart reviews. Other days I may see up to 12 to 15 patients and have a pretty long day. So you have to be accepting of a variable work day. There are scheduling issues within TMP, which is the scheduling platform that I use, that can arise. This has been greatly decreased by having a dedicated administrative team through the Clinical Resource Hub managing my schedule so I don't get double booked or triple booked, which has happened. When I'm on vacation, like I said, I'm sort of a lone wolf out there. No one covers me when I'm on leave. So new consults don't get performed until I get back from leave. And technological issues, as always, if you've done telehealth, can arise, which causes you to have contingency measures that need to be in place prior to the appointment so you can still continue to provide that care in that time frame. Next slide. Thank you.
I'm Dr. Audrey. Hi, I'm Dr. Audrey Yaddick. I work at the Oklahoma City VA. And actually, I work on our inpatient geropsychiatry unit. But I'm talking about a program that we have to our state veterans homes to help provide geropsych care to them. if I lapse, we call them vet centers here. So sometimes I might say that. And we also have the other things that you probably call vet centers in your state. So that makes it nice and confusing. Next slide, please. So we formed an interdisciplinary team with psychologists and psychiatrists to develop this program to reach out to the state veterans' homes and help address their needs better. You know, we found out that there really wasn't a lot of education about behavioral health in those environments, and a lot of them don't have anybody, they don't even have a psychologist or anybody on staff to really help train the staff in mental health and even just provide support. So we have 7 state veterans homes just within the Oklahoma City area, and then there's 2 in the Muskogee VA catchment area, which we also offered the services to them. One of those veterans homes declined it. They said they didn't have anybody with psychiatric problems, and so they didn't need it. So that was their choice. Most of the state veterans homes are located an hour or more away from the Oklahoma City VA. And like I said, they just don't have any training. Next slide, please. So initially, we just had adult psychiatrists seeing these patients through tele, and it was pretty well received by the state veterans homes. And they would prefer to have a psychiatrist come physically to the home and visit them and see the patients. But I think that they felt like they really needed some help and support with mental health. So they were glad to have it. You know, the veterans can receive specialized care without having to travel, you know, maybe an hour and a half here and then an hour and a half back. So it's a lot easier on them. And some patients with advanced dementia really wouldn't be able to tolerate that drive at all. So they're able to get care that they really wouldn't be able to receive otherwise. Next slide, please. So sometimes if the vet has a history of violence, they won't want to sit with them in the room while the psychiatrist sees them and evaluates them. So then they kind of don't have access to telepsychiatry. So, and then the staff have to have access to CPRS to put in the consult to get to us. And then our staff is able to log into their medical record system, which is called Point Click. So once that consult is typed up, they copy and paste it into Point Click, and there's also a copy in CPRS to see what was recommended. You know, sometimes the families will decline a telepsychiatry eval. You know, I think sometimes they just don't understand what it's about and how important it is. Next slide, please. So for one of our cases that we had a patient with dementia with behavioral disturbance, and then when the patient was seen, actually like 14 family members showed up to show their support and love and how important the veteran was to them. And they were able to provide a lot of collateral and history. You know, and of course the behavior improved, but it also just communicated how important and how much they care about that veteran. And they were able to feel good about it because they were able to participate and their voice was heard. Next slide, please. You know, before we're able to have the appointment, we have to get consent, which is usually the family, because they a lot of times have dementia. The consultant's able to get in there and read the records of what's going on with the veteran. And then usually a staff member, like a nurse that's familiar with the veteran, will kind of bring them to the appointment. Family are encouraged to participate if they're able to by phone or by physically coming there. And then, like I said, the full consult is placed in the chart with their local primary added as a co-signer to that note. Follow-up is kind of limited. It's kind of based on what the veteran needs. If they're able to get better after just one visit, then that's fine. A lot of times the visits are spread out 3 or 4 months apart. And also, if the patient needs to be hospitalized, since we do have a geropsych unit, I work really closely with our consultant, and she'll let me know sometimes when patients need to come in. Next slide.
Okay. Well, I believe at this juncture, we'll switch from those awesome presentations that reflect more about long-term care to the outpatient setting. So the next slide. And so I'll start with a program I initiated for outpatient services 2 years ago in that completely different world that we lived in then. I was interested in developing a telehealth program, which was more novel at that time. And so I worked with my group here. We have a geriatric outpatient service at the Tampa VA, but I created from that outpatient service a virtual integrated telepsychiatry for aging program. And I was exquisitely proud of the VA acronym VINTAGE. So I received a very small grant, next slide, which was a VA Innovation Award. And it was really just a tiny bit of clinical money to provide wellness trackers or step trackers because the vintage integration piece was meant to incorporate some sort of health behaviors into my outpatient service so that I could sound relatively interesting. Now, the bigger piece to this, I think, is not so much the wellness, but the importance of this outpatient service that I think is relevant outside the VA is the idea that the older mental health patient might be particularly amenable to a telehealth follow-up, given the idea that they're not necessarily a group, especially new referrals to mental health care, may not be necessarily all that interested in sitting in a psychiatry clinic. And certainly in the VA, we know that going to a general mental health clinic in the VA, you might see people who are in a buprenorphine follow-up program, in MICM programs for chronically mentally ill. And that may seem a little bit of an adverse environment for someone you're trying to engage in mental health services for the first time in late life. And the graph that I'm showing here is really an example of that really important gap that I think is important really nationally, even outside the VA, which the blue lines here show the aging population of veterans who are eligible for care. Sort of the proportionate age groups is what this is showing. And we see in the blue lines, the age distribution is weighted toward the 65 to 74-year-olds. The red bar shows utilizers of VA services. So proportionately, there are more VA utilizers per eligible veteran in the 65 to 74-year-old age group. What that tells me, it's a really important area in the VA to pay attention to, because that group is very likely to be experiencing new onset anxiety, cognitive issues, sleep issues, the whole gamut that we see with aging. And they really don't have a clear home for new services in the VA necessarily. Now, the VA does have primary care mental health. It does offer within the primary care setting some emotional support services, but for psychiatry or psychopharm follow-up, typically a mental health referral is generated out of there. And so the idea that telehealth can really accommodate that group was part of the reasons 2 years ago why I was excited to start this as an access point for older individuals who may not be as amenable to walking into a psychiatry clinic as younger adults. Now, post-COVID, I can see a great deal of opportunity that I'll talk about here to maybe fine tune these types of services and continue to expand opportunities for access that are afforded by telehealth. Now that everybody's become Zoom competent, we hope, and will continue to be, now's the time to really do a better job tailoring new ideas. So with the next slide, I'll talk a little bit about, as I reflected, as I started this program before the pandemic, I started looking at, these are outpatient referrals, so this is a quite different population than long-term care. These are community dwellers, often not long retired. There's a very high SES group coming back into the VA that aren't previous utilizers of the VA at all, who now are worried about cognitive changes. So a lot of referrals sort of address some of those interesting problems that perhaps we haven't seen before in the VA. When I looked at barriers to home telehealth, it's very similar to what we're seeing now, looking back on the pandemic. People still sort of prefer face-to-face interactions. People still struggle with email-based links and access points. And there are a number of health issues related to aging, such as tremor or need for assisted facility care. That might be a barrier to implementing telehealth. And so even at initially what I looked back on, very similar to what we're seeing now, is it felt like about half the time there was some issue with the video, camera didn't work, I'm yelling, can you hear me now, half my day. And so those are things that we're working on with barriers in the system and actually nationally. Now, the learning curve, as we reflect now, is software improvements have dramatically improved in the VA. I feel horrible a pandemic was necessary to make these great leaps, but the great leaps have been made in software access, at least within my area. However, even real recent survey data we've taken within some of our activities in my group, there's still providers and patients still tend to default to telephone. Now, some very recent data that just within the last month we were collecting from providers suggests that success seems to increase if there's a partner in the home, you know, a spouse. And so a lot of times I'm interacting with a veteran, and if there's a problem, they're hollering for the spouse who's in the next room. So it's a team effort. And secondly, multimorbidity, which is a big issue in the VA, seems to be also a barrier. And I'll talk about that on the next slide. And so also, as I reflect on the population that I have been recruiting now with a great acceleration within the last year in people willing to do home-based telehealth, what I'm looking as I start to think through this population who are community dwelling older adults that are now engaging in mental health care, often for the first time in later life, it seems to fall into about three main groups that might be amenable to future thinking about telehealth teams or specialized home-based teleclinics in the future. And one major group, probably the largest group, is the older adult in the VA with multimorbidity. And that means 3 or more significant chronic medical problems that create disability. And in the VA, that's often severe chronic pain, ambulatory issues, post-traumatic stress, very poor executive function issues that lead to low motivation and sometimes poor adherence to treatment plans. That group, as we think toward the future, is really perfect for my original idea of sort of wellness measures. You know, get a pedometer and things going so that there are goals for general health. Now, the second major group that actually did better in connectivity with telehealth is the dementia-related behaviors, because then you have a caregiver who's very often motivated to make video work. And it's been an amazing, you know, little group within my follow-up that clearly benefits from this type of access. That is a perfect setup for a telehealth team that might involve social work, psychological support for caregiver distress, and a lot of neuropsych testing online. There's a lot of opportunities for a teleteam that targets that group. And then lastly, there's the primary mental health patients who do better with compliance for, say, chronic depression or other, perhaps sometimes long-term mental health issues that now need attention. They would do well, they often do well with, companion groups, with psychology groups or other types of vet center psychological support groups as well. Now, post-COVID, it's clear that there's so much opportunity to expand these different areas, and social work integration with some of our telehealth services would be a lifeline, certainly for what I do. And I'm finding that I'm a connection to basic primary care needs for many veterans. In fact, in the VA system, we have had the crisis line being used as the only connection sometimes to address a primary care issue. In our system, we had the crisis line used to make a podiatry appointment. So that's the kind of connections that we can make in a more effective way through telehealth, so that other connections perhaps are enhanced and veterans get the support they need. So next slide, almost the last. And so when we think forward to the future, I think there are a lot of opportunities to think about this cohort of geriatric veterans and older adults in the community broadly, to think about, now that we've got an enhanced video platform, how can we bring in teleteams, we've got great advances now in neuropsych testing, at least at our facility, that are finally, more capable to do more things online than previously available. Social work integration, expanded dementia caregiver support. There's a lot of opportunities now, and I would love to see the AAGP and our group work together to think about different programs to develop greater expertise in telehealth teams. My team right now is feline assisted telehealth with my cat, but I would love to work with, I do basically outpatient primary care as a sole provider. There's so much opportunity to do a lot more. So I'll finish up there.
Hi, so I'm Lisa Boyle, and I'm a program director at the University of Wisconsin's Geriatric Psychiatry Fellowship Program. So I'm going to be talking about the perspective of using telehealth and offering these kinds of services while also trying to serve the role as an educator, a clinical educator. So we're going to be focusing a little bit about kind of my role as an outpatient geriatric psychiatrist at the VA, but also that we have a very robust training program. And so how do we incorporate our students, our residents, our fellows, and interact with each other using telepsychiatry services? If you could advance the next slide, please. So I just wanted to give you a little bit of perspective. Prior to COVID-19, the way that our geriatric psychiatry teaching clinics were set up at the VA was that our geriatric psychiatrists would have a mix of different types of visit in a half-day clinic. So if we were seeing patients in the morning, our 8:30 appointment may be in person. Our 9 o'clock appointment might be by a kind of video connecting with a local rural clinic, like what we call our CBOC, which is a community-based outpatient clinic that's associated with a larger medical center at the VA. And so that would involve someone at the clinic checking the patient in and setting them up with the video monitor, and then you could connect with them over this kind of format. And then maybe my 10 o'clock patient might have been a video connect to home, where the patient is using their own equipment to be able to communicate with me. And so that's kind of like it gets kind of complicated because you have different kind of schedules, and you would have to kind of keep track of, okay, which appointment is what. And we relied very heavily on our medical support assistants and our schedulers to help kind of provide us with a cohesive schedule so that we could kind of move very easily back and forth across these different formats. The advantage was it provided a lot of flexibility, and it also provided an opportunity for any of our trainees who are working with us to get exposure to all these different kinds of ways of connecting with our patients and families. When we were before COVID, we did not incorporate video connect to home capabilities for our initial intake. So all of our initial evaluations with patients would require that that patient and their family come to the clinic or come to that local, to the hospital. We just didn't incorporate like video connect capabilities to home. Our team compositions, just so you kind of get a scope of who's involved besides the geriatric psychiatrist, we have a geriatric mental health social worker who works with us directly for all of our new intakes. So the way that our system is set up, our social workers will meet with the patient and family first, and then they do a warm handoff, and then the psychiatrist meets with them. There are some flexibility. There are times that based on the situation or the patient, we may decide to do a joint evaluation and meet with everyone together as a group. So it allows us kind of some flexibility, and we have a very active teaching clinic. So in addition to like medical students, we often would involve our geriatric psychiatry fellow, we have geriatric medicine fellows, and sometimes we have visiting VA geriatric scholars who would participate in the consults. But the challenges of kind of pre-COVID was, you know, sometimes there's just too many people in the room. So we would have to be very kind of mindful of how many trainees that we could kind of involve in each intake. For follow-ups, just wanted to mention our geriatric psychiatry fellows have continuity clinics, so they have their own panel of patients that they follow that I supervise. And pre-COVID, they were pretty much our only trainees who did some video connect to home. All of our psychiatry residents at that time did not have the capability of using that technology. It was really staff as well as our fellows. And that's really changed since COVID, as it's changed for a lot of us. So some of the changes since COVID is that we've really brought in video connect to home capabilities right from the start in terms of our intake process, as well as with follow-up. All of our residents now are required to get training so that they can be able to use the video connect to home capabilities. Our grids still remain mixed, but I would just say, just as Dr. Schultz had mentioned, you know, by far the preference for a lot of our geriatric veterans are still to prefer telephone over video connect. Although we're seeing some increased movement in that area, and our VA has done a lot of really nice work with providing local support. So we have an actual local video connect team that we can consult with. So if we have a veteran who's willing to try it, they will actually meet with the veteran remotely before the next appointment with us so that they can troubleshoot and test the system to make sure it's working before their next appointment with us. So I've actually seen some major improvements in that area and some increase in uptake, but I would still say it's maybe about kind of about 20% of my patient panel that are using video connect, and still by far most people want to do telephone. And we have actually opened up some in-person sessions as well, just because of communication challenges. So like yesterday, I had a veteran who is so hearing impaired that we really can't communicate through video connect, and we can't communicate through the telephone. So we've had the discussion with him and his family, and he comes in to see me in person so that we can facilitate communication and get him the care that he needs. I also just wanted to mention that since COVID, one of the things that really has there's been some benefits is that we now can kind of incorporate some more trainees in some of our intake evaluations, because what we do is we use multiple rooms to complete the evaluation, but we're connected through Microsoft Teams. So like one person could take the lead on an interview, and other people can be listening in or watching through a connection through Teams. And that actually has been working out really well. So our typical intake, like I did intakes yesterday, we had a mental health clinical pharmacy resident working with us. We had a geriatric medicine fellow working with us. We had a medical student doing a geriatric psychiatry elective. And then we had our social work intake person and me. And we ended up using 3 different rooms to try to physically distance during COVID, but still stay connected in real time, being able to talk with each other through Teams, listen in on how the intake was going. And it's been really, when this first started, I was like, how am I going to teach, remotely? And it's really been eye-opening in terms of how there has been some increased opportunity and, in the face of hardship, like trying to think innovatively and thinking about different ways of doing things. So it's really invigorated, I think, me as an educator to really kind of think about some of these challenges. The other thing I would just mention is during follow-up appointments, we're not actually on site at the hospital. So we're all working from home. So today was my teaching clinic for geriatric psychiatry, where we do follow-ups. And so I was working with, we have 2 different residents in our follow-up teaching clinic. One is a 3rd-year psychiatry resident, and one is a mental health clinical pharmacy resident. And so we do team huddles to start the day, where we kind of game plan and strategize, talk about the different cases that we're going to be working with today. And we're all working from home. And then what we can offer then is, there are certain patients that I will see virtually with the resident. So through the VVC capability, you can send the email invite to multiple people. So you can have 3 different screens going, where we're all talking with each other, seeing each other, and you're in 3 different geographical locations. So that has been really beneficial, so that we can give real-time feedback. We also do drop-in supervision. So I might just join a session partway while they take the lead initially, and then let me know through Teams when they're ready for me to join. And then we staff the case then. And then we also offer, at times, we'll do indirect supervision, where I'm not directly involved in that patient encounter, but we discuss the case afterward. The other thing that has happened is that our didactics have really opened up. So one of the things I've noticed is that it's been a little bit easier to kind of be able to join different didactics and to run different didactics, because you don't have to worry about everyone's at different places. We can all join in this way. So we've been doing a lot of using different formats like Teams, like WebEx and Zoom to do kind of other teaching. Next slide, please. So some of the lessons that we learned is that, it's really important to have really good support from your schedulers to kind of keep your schedule on track. We can designate who the links are sent to, so they can be sent directly to our trainees so that they can prepare as well. It's important to stay in touch with communication. So Microsoft Teams has been really valuable for us to continue to stay in connection with our trainees in real time. Generally, we like to schedule longer appointments if we're using Video Connect with some of our complicated gero patients, because, just in terms of troubleshooting, and also involving caregivers. So one of the things that has been really wonderful to see is, because of the lockdowns, we do this for skilled nursing facilities as well as video connect to the home and memory care units. And when, because of the restrictions and visits, sometimes these are the only opportunities that families have to be able to visit with their family, to see them and talk to them while they're joining us in session. So that has been really, really wonderful to see. And we can provide real-time feedback to our residents. So if they're taking the lead in the interview and we're observing, we can send them kind of guidance while they're doing the interview and not be intrusive, and so kind of providing them coaching on, what to go for next. Next slide. So again, there's been a lot of benefits, I think, in terms of using telehealth in working with our trainees. It has provided a lot more access to different kinds of learners joining in, to people being on the same page, and kind of getting feedback while they're doing the interview in a kind of intrusive way. And it also has provided opportunities to really kind of look at the home environment. We've also been able to coordinate schedules with home visiting nurses so that, they're the ones who are actually facilitating the technology. And it really helps with coordination of care when they're able to be there during the appointment that they have with us, so that they're kind of listening in with the vet's permission and helping with coordinating and providing collateral information. There's also really wonderful exposure for our trainees as well. The final slide, please. So the one challenge I would say is reiterating what Dr. Schultz had said, challenges with the technology itself, and also just kind of limited ability to focus on physical aspects of the exam, like teaching the neuro exam and different types of cognitive approaches in terms of testing. And you don't have as much structure, so you don't have that nurse who can kind of check that patient in and do the vitals for you. So we've had to kind of adapt in that way. And some trainees do express some discomfort with using telehealth at times. So you want to make sure that they feel safe and talk about, kind of like what to do if there's an urgent situation or emergency. You want to make sure that you're there and available for them. Thank you. Next slide. Oh, and then the next part is Dr. Oslam is going to lead the discussion.
Okay. Good evening, everybody. Thank you for joining. I just want to say thank you for all the panelists for their wonderful presentations and for the opportunity to ask me to be a discussant. I appreciate all your invitation and kind introduction, Lisa. I think I don't want, in the interest of time, I want to be short and sweet. I think all you probably saw at the beginning, there is a huge demand for geriatric population, and telepsychiatry has opened up the avenue for the opportunities in different settings, whether it's outpatient through VVC or CBT, inpatient, CLC, e-consult. I know I was one of the skepticism at the beginning, but I started it and I'm feeling more and more comfortable. And especially with the pandemic, I feel so blessed that I can work from home. That's the biggest, and it's not only, actually I feel safe, it has cut down my commute time. I live north of Cincinnati and work in Cincinnati main VA, which is in the downtown area. It used to take me 45 minutes. Again, my job satisfaction has increased. I will love to continue that. And that's what I've been told, that even post-COVID, we will have probably 70% of the mental health care at our VA will be through the tele's mental health. And just like Lisa said last time, I'm also involved in the fellowship. I was fellowship director for about 10 years now. I'm the site program director at the VA. We always struggle because we are in different locations at the university, outpatient buildings, and pharmacists, and there's a across the river, there were some pharmacists who would like to attend, but this has opened up the opportunity that we can all, at different locations, we can be together. And I think it's very well attended. Initially, we had quite a bit of struggle with that too. With that, I think I will, because we have maybe 10 minutes, we would like people to ask questions and be interactive with us. We want to learn from you, want to listen from you. I will stop here and thank you very much. I don't know, you guys want to take questions or should I go ahead and read it? Or Lisa?
Yeah, so sorry about that. So it looks like there's a question from Dr. Kalenda. So the current cohort of geriatric patients represent those veterans who were in Vietnam. They have had substantial challenges over the years, especially with depression, PTSD, substance abuse, and suicidal behavior. How are crises managed, especially with suicidal ideation?
I would be very happy to speak to that. That is absolutely right. And the effect of social isolation on that group right now has been a very, very difficult time. Thankfully, the VA has done really, in my view, an exquisite job creating access points. So for example, I had a very recent scenario where within the VA Video Connect system, if you're on the line with the patient, there's actually literally a button that you can push that will activate emergency services, and they have it linked into when the veteran signs on to the system, they put in the address that they're located. You know, that's worst scenario that I have not had to use, but the VA, because of the very significant suicide problem among older adults, broadly speaking, and especially in the VA, I had a scenario, for example, in the VA where I'm online with a patient. This was a telephone call. We have a suicide alert team that's available through, this was when we had Skype, but Teams at any rate. So through instant messaging, there is a VA service that is instantly available if there's a concern or a question for the suicide prevention team. And I had a veteran online where I quickly Skyped the team because I was very concerned he was going to take off in his car and he was escalating on the telephone. The team was able to keep instant messaging with me and contact his local law enforcement at the same time that I was talking to him. And they were able to message with me and even convey what I was saying to the law enforcement while I was still trying to de-escalate the patient. And literally the law enforcement showed up and was speaking to the patient while I was still online with him. It all happened in a very, probably the best outcome you would want. And they were able to sort of take over and conduct an assessment of, you know, what needed to happen immediately. So I think that is the best scenario. And I hope that most telehealth systems have some other type of system in place that has the same type of access. At least that's been my experience in the VA. And I think any telehealth system has to, because you are in a place where, you know, I can't, you know, I can't, I'm not there. And I had another situation where a patient got dizzy. And so we also have access to, you know, their next of kin and that type of thing. That patient happened to be in a clinic, but I was able to instant message the nurse that the patient is getting faint. And so I think, especially with our frail population, you have to be prepared for that kind of thing and have a plan to work around the limitations of telehealth. So.
Thank you. There's another question that came in from Dr. Diaz. How has the VA handled getting the telepsych equipment to the patient in their homes? I know at our VA, we have tablets that you can request to be sent to the patient if they're interested in trying this and they don't have access themselves. I would just say one of the challenges that we've run into is some of our rural areas do not have really good high-speed internet or there's still connectivity issues that we have not found a way to overcome. So other people, if they have similar experiences.
Yeah, I agree with that. The one thing benefit with the tablet is there is a link already built up. We don't have to send the email link or anything like that. If the patient don't have their email, you just click on the link and the session pops up. And that's the one I think that's what I like about the tablets.
Mm-hmm. It looks like there's some more questions that came in as well from Dr. Santos. She had 2 questions. Can family join through VA video connections like they can through Zoom? And the other question was, not being familiar with Microsoft Teams, does the patient see everyone on the team screen?
I can answer the Zoom question. This is Dr. Phillips. Yes, multiple family members who are not on site, as long as they have that link, can enter that virtual room, and the person that controls it is the provider. So once everyone is in the room, you lock it for security reasons and privacy reasons, just as if you were shutting your door in your clinic office. So if there are outside family that want to join, and I certainly in my program, and I'm sure with everyone else, you welcome as many family members as want to join at times to get a clear picture of what's going on. So that is able to be done. And then I'm not familiar with Microsoft Teams. Does a patient see everyone on the team on the screen? I am going to defer that to someone else. Not use Teams with patients.
So basically they can't. So it's just a way of allowing people to listen in. So like, for instance, if you had the video connect on, we would always let the veteran know and get their permission that other people are going to be kind of listening in. And then you can pull up the Teams and connect either through phone. Usually it's by phone, so you don't have 2 different videos going, so that people can listen in. And there's different ways of doing that as well. So like, even if you were in an interview with someone and you had the video on, someone else, like the rest of your team, could be watching you with the veteran's permission if they were in front of you, and they could be observing, but be in a different location. So it does provide some flexibility. The other thing we've used a lot is the doximetry dialer as well, as a way for communicating and doing kind of like 3-way calls where, the resident might have reached out to the veteran first, and then they add me in to do drop-in supervision. Additional questions we have from Dr. Lakeland. How are you connecting Teams to the telehealth software for students? I think I just answered that. And then Dr. Horn, it looks like, curious whether nursing might do video conference vital signs. I haven't actually seen that in my practice. I don't know if anyone else. When you're doing video connect to like a local clinic or like an assisted living or like a nursing home, we can access the nurses there. But in terms of to the home, I know that there is like a telebuddy system that the VA sends out to some people, and it helps them track their blood pressure and, different types of, scales that are used. But I don't know that it's really built into it's not really built into Video Connect.
No, but a lot of our veterans are very good at tracking that. You can take their blood pressure themselves for the most part. They can do everything but respiratory rate. And a lot of them have pulse oximeters. So you can just ask them.
Pulse oximetry, vital signs, blood sugars, they can monitor and send it to them. And you can see in the CPRS records.
And then there's a question from Dr. Horn. If you have a current non-psychiatric medical concern, has anyone developed a model to have immediate internal medicine, geriatric, or family practice doctors who could take over, including helping get EMTs online if needed.
Once again, I think we use that E911 link in our video conferencing virtual window to home. It's not just for psychiatric emergencies, it's for all emergencies, and you can get emergency personnel there. I have not experienced primary care or internal medicine taking over my call immediately, since I do work from home.
I've had one situation where I was talking with a veteran in his home, and he had, like, it's actually been a few situations where he's had some other concerns, like I'm feeling more fatigued, or I'm having more shortness of breath. And I've used Teams to connect to our nurses triage line, and then communicated with them that as soon as I was done with the patient, they would be reaching out and calling that patient to assess. So I feel like that's one of the really fortunate parts about being a part of the VA, is you have a lot of access to resources. It's really, even though I'm working from home, I feel very supported.
Right.
Like
And
the
I think-
home-based primary team, I would say that I have, like if I'm talking to a veteran and they have medical need or some urgency, or not really urgency, but maybe needed right away some attention, I have home-based primary care physician, psychologist, nurse practitioner. I send them message through, our Microsoft Teams, and their issue can be resolved same day, if not, maybe next day or right away sometime. I have psychologists who have done sessions on my behalf because I did my medication management, and I thought patient needs some support today because of pandemic, stressed out, can't go out, lockdown, assisted living, and that I'm able to seek some help.
And I think a beautiful thing the VA did at the start of the pandemic is they have a VA clinical care line. It's an 800 number that we were asked to add to our voicemail response. So there's a clinical care triage center that if a person has a concern that they don't know where to go with it, to try to prevent urgent care visits. Obviously, we don't want people presenting to urgent care if they could be triaged in another way. So I think that was another really awesome thing the VA rolled out with the pandemic.
And it looks like there is another question from Dr. Olatunda. What about vets in nursing homes that like to leave the nursing home for their clinic appointments as a way to alleviate their social isolation?
I think definitely, and I'll defer to long-term care folks too, but I think one thing we have learned for all of our older patients is the clinic is a very social place, and the VA is a very social place. And it is a very big deal for a lot of our older gentlemen where it's their day, it's their social network. And I think we have to be very aware of that and very attentive. And there isn't an easy answer to that question, but it's absolutely correct that our patients really value the connection to other veterans. And I think the VA has tried to make more social connectivity because we've got more virtual services available. But I think that's a great future direction to try to create more social support services and think about how to do that virtually as a way to try to offset some of that social isolation.
Yeah, and just along those lines, like, our whole health team has been so wonderful during this. Like, they've developed now all these virtual and telephone support groups, and Tai Chi through virtual, teaching Tai Chi virtually through the VVC, all sorts of different kinds of options that before a lot of our rural veterans would never have been able to access. And now they can, have more options for additional wellness. There's a question from, it looks like a question from Dr. Marpuri. Is telehealth being used in inpatient psychiatric units at any of the VA hospitals?
I know that there is a VA in Muskogee, Oklahoma, and they have been using telehealth because they had a lot of their psychiatrists quit, and this was a way to staff the inpatient unit. So I know they're doing that.
And it looks like Dr. Vidalia, on an average, we are needing 25 to 50% more time to complete video visits compared to face-to-face visits in clinic, and about 25 to 50% less time in nursing home visits. Do you have similar experience?
Speaking from my experience, it really depends. It depends on the patient and the number of people involved in on the call. So it depends on the problem that presents, as well as if there are strong concerns. If there's no concerns, obviously it's a very brief nursing home type visit that I have for follow-up. Otherwise, video visits can take a little bit more time than average, trying to set it up and make sure everyone can hear, and with glitches factored in, it can take a little bit longer, but sometimes they go very smoothly, and it's like a typical nursing home visit that's very brief and just reviewing labs and seeing the patient, and everything's great and good.
It looks like, have you tried, Dr. Lakeland, have you tried groups through televideo formats? I personally haven't led a group, but our VA does offer, they have been offering like groups for PTSD and depression and all sorts of different types of groups. Even I think DBT, our substance use disorders program is offering groups through Video Connect as well. And so I know that there's been a lot of efforts to try to increase access since COVID. And then Dr. Raghunathan is asking, or in the Ann Arbor VA, we were able to use Video Connect to evaluate patients on the COVID floor, especially on call.
And I'm even doing that at the St. Cloud VA. They've dedicated one unit as a COVID unit, and they don't want to take those patients to the typical telehealth room that they have on other floors. So they have me see them by tablet. That is being done.
I know our VAs did that as well, so that it would try to minimize how many people go into the rooms. And also for, you know, in terms of like, sometimes we'll have people walk into our walk-in clinic, and to try to kind of mitigate risk of, you know, sitting in the same room for an hour session, we've had our nurses check people into one office and set them up on the video monitor, and then we're in a different office and we communicate this way. So it really depends. We can't do that if there's communication challenges, but we've been trying to be very mindful of how much space we have and how much time and exposure people have. So it looks like if anyone wants to share their experiences, we'd love to hear from you. You know, just to have an open dialogue. If you wanted to use the raise hand function, we'd be more than happy to kind of open this up to everyone, because I think we're all learning together. I guess while we're seeing if anyone wants to do that, it looks like there's a few more questions that have come into the question and answer. So it looks like Dr. Chatalani is asking, how are tests like MoCA done, or like an Allen's test by OT if needed for patients at home?
Like,
I
That's a-
have not done personally
Yeah.
myself, but our neuropsychology service is doing brief neuropsychiatric evaluation through the BBC. They don't spend comprehensive, but they give us some idea what's going on with the patient once we consult them for if they have cognitive issues going on. And we ask them evaluation. They do run battery of tests and give us a brief neuropsychiatric evaluation through BBC. But I personally have not done this. I think it will be hard to do.
I will say into the home, it is, waiting on neuropsych to the home, it's great. But if you want to do a brief screen, it is very difficult if you've got no one else there. Things I've been able to achieve are, you can learn a lot from the 5 words. So in my house, the people, the pool people can probably hear my 5 MoCA words as I'm screaming them into the computer every day. But using those, and sometimes you can sort of demonstrate and ask somebody to draw a clock, and I've tried to do some of the basics. I'm sure we all have. And usually if you talk long enough and you do some MoCA basics, you can get, I can ballpark it, which I think in the best interest of the patient, that's the best I can do. And I think I'm probably not as far off as I fear sometimes. At least as long as I'm consistently inadequate, as long as I'm consistent about it, I can tell change. So I don't know if others have worked out anything better, but the pieces of the MoCA, you can do a fair amount.
Yeah, I mean,
you can do a blind MoCA,
Yeah.
which is
Right, exactly. That's my Susan version. I don't know. I haven't been formally trained on what a blind MoCA is, but is there a formal training on the blind MoCA? So somebody send that out.
Yeah, it's just taking off the first few parts of it. So it's
So you
scored off of
skip
22.
the clock?
yes.
You skip the clock, you skip the trails, you skip the pictures, and then you can convert the score. But there's still a lot of challenges. Like I just did one today in clinic, and the hearing, it's like, it's just, kind of difficult sometimes. So, and then it looks like Dr. Vidalia asks, how do you assess neurological symptoms, functional status, adverse effects from medications, and gait balance in nursing home patients with advanced cognitive impairment? Are you using PT and OT staff?
I myself am using nursing staff. They perform either an AIMS or a discus on a routine basis for those that are on antipsychotics. You can gain a lot by seeing how they present to the room, what their gait is doing, especially on subsequent exams, or if they're in a wheelchair. There was one patient where I asked a psychiatrist to come down to the nursing home unit in Des Moines, Iowa, because there was suspected catatonia, and obviously you cannot do that exam over Video Connect. So we contacted the local mental health clinic, and the psychiatrist was willing to evaluate them for catatonia.
And it looks like there's a comment from Dr. Soto Moyes. No question, just a comment. I'm a psychiatrist at WBVA in Pennsylvania. I'm sorry, I don't know what that stands for. In agreement with previous statement that our demand for service is high, but VA telepsych service is excellent. All staff has been very supportive, so patient care does not get compromised during this pandemic. And then we have a question from Dr. Horn. Are you able to hold groups in VVC in different homes? I have done some sham med management therapy group when working at a CBOC, had a robust number of group members without a room large enough for all. I'm not sure. Does anyone?
So the
Just-
question is, how many people will VVC add to a group call?
Yeah. I wish, I
Yeah, I
don't
think
really,
that's- yeah.
personally, I don't have any experience with that. I'm sorry.
Yeah, I don't do groups.
I do know our program is offering groups, but I just don't know like how that, I've just never had any personal experience with like how that's set up and how that's arranged. But again, our alcohol treatment program, our PTSD program, they've been, and our mental health program have been offering different types of groups.
And likewise, in Cincinnati, we have people who are doing even CBTI for insomnia. We have one psychologist and one nurse who does that. But I personally don't have experience doing that.
Oh, sorry, Dr. Sotomoyes, it was Wilkes-Barre VA Medical Center. All right. Any other thoughts or questions? Okay. Well, I just wanted to remind people that there is the link for feedback on today's session, and we really appreciate everyone's time and interest, and thank you so much for joining us. We really appreciate everything that you all do.